So why is there a cherry red appearance? That is because the retina in the posterior pole has just a single layer in the ganglion cell layer, that is, except in the fovea. The retinal periphery too has just a single layer of ganglion cell layer. Central retinal artery occlusion causes cessation of axoplasmic transport. This, in turn, leads to opacification of the retinal nerve fiber and ganglion cell layers. The earliest characteristic changes seen in CRAO are retinal whitening in the posterior pole and cherry red spot. This is seen where the ganglion cell layer is greater than 1 cell thick, except for in the fovea and peripheral retina. Now let's recall that the inner layers are nourished by the retinal artery and the outer layers are nourished by the choroidal circulation. So the area with the thinner retina is still sustained by the choroidal circulation, and hence it just basically is normal retina seen in contrast against the opacified retina, which is ischemic due to obstructed retinal arterial circulation. Patients usually present with sudden monocular painless severe vision loss, and in some cases might report a transient visual loss or otherwise called premonitory amaurosis fugax. Visual acuity at presentation can vary from perception of light to counting fingers. Presenting visual acuity can be predictive of visual acuity at recovery. The presence of an embolus usually signals a poor outcome. So what do we see in the fundus? The most commonly reported findings are cherry red spot and posterior pole whitening. The other findings that can be seen are box scarring of retinal arteries and veins, retinal arterial attenuation, optic disc edema, and optic nerve pallor. All these are predominantly located in the posterior pole with a normal appearing periphery. CRAO can be of the non-arteritic or the arteritic type. Non-arteritic type can be of the classical variety where the findings of retinal whitening and cherry red spot are seen, or it can be of the cilioretinal artery sparing variety where the cilioretinal artery region is clinically seen to be perfused, or it can be of the transient variety where the occlusion lasts for a short time and clinically cotton wool spots are seen. Arteritic type is usually due to giant cell arteritis and it's associated with arteritic anterior ischemic optic neuropathy and clinically will have the classical picture described previously.